Now, welcome to the module of regional conditions. In this module, we'll be discussing multiple different pathologies, but they have a common theme. What is the common theme of these multiple different pathologies? The common theme is that they occur because of cumulative injuries. They occur because of cumulative injuries. What do you mean cumulative injuries? It means there is repetitive minute injuries, but over time they manifest with something big. For example, if you repeatedly injure something minutely, over time it will become a major condition for pain. That is what this module includes. Now, none of the conditions are interrelated to each other, but their presentation is the same. What is their presentation? Pain. Pain at a particular part of the body. Now, this pain will usually be exaggerated on performing one unique activity. Right? For example, in tennis elbow, I'll explain everything, but for example, in tennis elbow, on extension of the wrist, there will be pain over the lateral epicondyle. And in golfer's elbow, there will be pain over the medial condyle on flexion of the wrist. Okay. So on a particular activity, there will be exaggeration of the pain. Cumulative trauma or cumulative injury disorder, pain on particular activity, and the treatment is similar. What is the treatment? Rest, immobilization, NSAIDs, physiotherapy, steroid injection or surgical intervention. And that is the only reason all these conditions are brought under the umbrella of regional conditions. But none of them are interlinked to each other. That is what I wanted to understand. Okay? So there is tennis elbow, there is golfer's elbow, there is trigger finger, there is bursitis. All of these conditions are different, but they present to you with pain, and this pain is exaggerated on a particular activity. So what I've done is I've basically divided them all the way from shoulder to the foot, and we will be discussing them from shoulder to the foot step by step. So the first conditions, the group of conditions that we're going to talk about, start in the shoulder. And there are three important conditions that I'll discuss here. First is frozen shoulder, other is impingement syndrome, and the third is rotator cuff tear leading to arthropathy. Okay, so frozen shoulder, impingement syndrome, and rotator cuff tear leading to arthropathy. Okay, so these are the three conditions we'll discuss in shoulder. Let's start with number one. What is frozen shoulder? Please listen to me. Like every other module, everything is written in the PPT. I want you to listen to me first to understand the story of how this patient will present to you. And once you know that, you can write down everything that is written in the PPT and I'll make you write down. But the point is to understand how the patient will present to you. And only then you will be able to make the diagnosis on the exam, because I'm telling you the exam is diagnosis based more than anything. Right. So what is this frozen shoulder adhesive capsulitis? Frozen shoulder, also known as adhesive capsulitis. So what is the story here? Listen to the story. The story here is this is a patient, usually a diabetic with poorly controlled sugars. Okay. Poor glycemic control wala patient. This is a patient who has not controlled his sugars properly. So there is a high HbA1c or high glucose level in this patient. And over time, because of this, there is inflammation of the capsule of the shoulder joint. We don't know why it occurs. So essentially there is capsulitis. And why is it occurring? We don't know, but it is usually believed because of uncontrolled sugars. 1 point. Next, what do you want to do? Because of this capsulitis, there is chronic inflammation. And because of this inflammation of the capsule of the shoulder joint, what happens? Adhesions will form. And because of these adhesions, what will happen? There will be restriction of shoulder movement. But please understand, there will be no bone involvement. It's a capsular problem. That's why it is known as adhesive capsulitis. So patient will present to you with pain, obviously, because there is inflammation. Number two, there will be restriction of movement of the shoulder because of the adhesions that form at the capsule. This is the story, right? Once you know the story, everything else is a fact, right? Let's look at it. So it's an inflammatory process which leads to adhesions or inflammations of the capsule, capsulitis leading to adhesions. So adherence of the capsule itself. Why does it occur? Mostly we don't know, but it's usually because of uncontrolled sugars. I'll show you. This leads to pain and restriction of all the movements of the shoulder. Obviously, there will be pain, and that adhesions will lead to restriction of movements. Usually, it is self-limiting, and 30% of the time it is bilateral. It's a fact you have to remember. Okay? It's self-limiting means usually it will resolve over time. So what are the associated conditions? Most importantly, it is diabetes mellitus, both the types, type 1 and type 2. What are the other conditions that can present to you with adhesive capsulitis? Thyroid disorders, hyperlipidemias, cardiac problems, Hemiplegia patients, prolonged hemiplegia patients, because of immobilization of the limbs, they can present you with periarthritis following trauma or surgery to the shoulder and idiopathic. Okay? So adhesive capsulitis, frozen shoulder, also known as periarthritis, because it's inflammation around the joint but not at the joint, periarthritis. So we have divided, for easy understanding of this condition, into 3 parts: the freezing, the frozen, and the thawing phase. Now, before you understand, listen to me. What is freezing, frozen, and thawing phase? In freezing phase, there is increase of pain. There is increase of pain at the shoulder. And in frozen phase, there is a restriction of movement. And in thawing phase, there is regain of the movement, because this is usually a self-limiting condition. So freezing, frozen, and thawing phase. So what happens in freezing? There is pain, usually presents night. The patient will complain of pain at the night, difficulty sleeping, gets up because of pain. And in frozen stage, obviously there will be restriction of movement. Now, because of this restriction of movement, we assume that because of this restriction of movement, the pain comes down. So pain comes down. And finally, in the thawing phase, movement starts to reappear. So stiffness decreases and so does the pain. So freezing phase, pain increases. Frozen, pain starts to come down, movement is restricted. But thawing phase, pain comes down and movement resumes. These are the stages of adhesive capsulitis. Okay. Now, how do you make this diagnosis? I have told you the diagnosis is mostly clinical, because the patient will be a diabetic patient who has poor control of the sugars, right? That is first. Second, there will be no history of trauma. There will be no bony problem, right? There will be no history of trauma. There will be no bony problems. There will be restriction of shoulder movement. Usually it starts with one shoulder and moves on to the other shoulder. Patient presents to you with night pains. So how do you make the diagnosis? Diagnosis is usually clinical. There is a restriction of the movement. Now remember, here's an important MCQ. The restriction of movement is usually global, and both active and passive movements are affected. Both active and passive movements are affected. It's a global restriction of movements, means all movements are restricted. Internal rotation, external rotation, adduction, abduction, flexion, extension, all of them are restricted. But it usually starts with rotation first. So which rotation is restricted earliest is an MCQ. So external rotation is restricted earliest, right? So you know the external rotation of the shoulder, right? This is the external rotation of the shoulder. Patient will be unable to externally rotate completely compared to the other side where the external rotation will be maximum. So you will notice that there is a restriction of external rotation. That is how you make the clinical diagnosis. Another important fact is X-rays are usually normal. Why is X-ray normal? Because this is not a bony pathology, friends. This is a capsulitis. Okay, so where will you pick it up? You'll pick it up on ultrasound. You'll pick it up on MRI. Okay, so how do you treat this condition now? See, it's usually a self-limiting condition. So if you advise the patient to maintain good glycemic control, usually it will self-resolve in a matter of few weeks to few months. You can support the patient with some NSAIDs to suppress the pain. That is all that is required. But sometimes these patients, they do not respond. And in those conditions, you might have to break the adhesions to allow for the movement. Let's see. The treatment, usually it's self-resolving. What you can offer is some kind of physiotherapy to keep the shoulder movement alive and ask them to keep on performing movements of the shoulder. You can give anti-inflammatory and analgesics to suppress pain. Steroid injections are controversial here because some advocate that they can suppress the inflammation, hence the pain will come down. But some other people say that these steroids, if used in a patient who has poor glycemic control, can exaggerate the poor control of sugars. That is why they ask you to stay away from steroids, but it's usually controversial. If a patient presents to you with adhesive capsulitis with good glycemic control, you can go ahead and give a steroid injection that can suppress inflammation. But if it's a very, very high, HbA1c is very, very high, glucose is not controlled properly, then be very careful. Now, rarely you might require intervention in terms of increasing the range of movement by manipulation under anesthesia. This is known as adhesiolysis, where you break the adhesions of the shoulder by giving anesthesia and performing movement at the shoulder. Or you can arthroscopically put a scope inside and fill the capsule with fluid, thereby breaking the adhesions. Arthroscopic or open capsular release. You can fill the capsule with fluid, and this fluid accumulating the capsule will break the adhesions. That can be done. We call it hydrotherapy, but it's not something that will be asked on your exam. So understand that adhesiolysis is something that you can do if the patient is not responding to conservative therapy. So what were the key points to remember here? Restriction of shoulder movement without any kind of X-ray abnormality. First thing. Second thing, usually poor control of sugars. So diabetic patient, usually. Third, freezing, frozen and thawing stage. Restriction of movement. The first movement to be restricted will be rotation, particularly external rotation. Those are the things you need to remember about adhesive capsulitis. Okay? Now the next condition that we're going to talk about in shoulder is rotator cuff tear and impingement syndrome. First we'll start with impingement syndrome. But before we talk about these conditions, I want to review the anatomy of rotator cuff with you quickly so that you're on par in understanding what's going on, right? To understand the story easily. Otherwise, you will read about rotator cuff anatomy in your anatomy modules. So quickly review what are the important muscles of the rotator cuff. You have 4 important muscles: supraspinatus, infraspinatus, teres minor and subscapularis, right? Now, quick quiz. Tell me the nerve supplies of these muscles. If you remember from your anatomy, what is the nerve supply? Pause this video, look it up also if you want to. Right? If you can't, just I'll tell you. Supraspinatus and infraspinatus is supplied by suprascapular nerve. Excellent. Excellent. What about teres minor? Yes, it's supplied by axillary nerve. Very good. Very good. And subscapularis, come on, tell me subscapularis for full points. It's supplied by upper and lower subscapular nerve. Right. Excellent. 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 Can you tell me from your knowledge of anatomy the actions of these muscles? Come on, try. You know this rest. Yes. Supraspinatus is the initiator of abduction. Yes. Infraspinatus and teres minor are external rotators of the shoulder, right? And subscapularis, what is the action of subscapularis? It is the internal rotation of the shoulder. Look at this very carefully. Subscapularis, it pulls the shoulder in. So internal rotation of the shoulder, right? Yes. And supraspinatus, initiator of abduction. Infraspinatus and teres minor, external rotators of the shoulder. Look at this over here. Remember, this is subscapularis, right? Subscapularis will pull and cause internal rotation. Teres minor, infraspinatus and teres minor will cause external rotation, and supraspinatus will cause yes, initiation of abduction. Okay. Again, look at this. This is your subscapularis, supraspinatus, infraspinatus and teres minor. These are the rotator cuff muscles. Taken, these are the rotator cuff muscles. And you remember subscapularis action is to cause internal rotation, supraspinatus is abduction, and infraspinatus and teres minor is external rotation. You know this from your anatomy. We quickly reviewed your anatomy. Now with this quick short review of anatomy, let's start with impingement syndrome. What is impingement syndrome? Impingement syndrome means something is getting impinged somewhere, right? Impinged or getting compressed somewhere. What is getting compressed? Let's see. So you see, this is an AP view of the shoulder. And what are you noticing here? You're noticing that there is an acromion and the head of the humerus, right? So this is an AP view. And what do you notice? The structures between the acromion and the head of the humerus. 2 important structures. Number 1, subacromial bursa. Okay. And this tendon, what is this tendon? Can you recall this tendon that passes under the acromion and inserts at the head of the humerus? This is your supraspinatus tendon, right? Can you see this? This is your supraspinatus tendon and this is your acromion, right? Acromion process and supraspinatus tendon. Henna, right? Acromion, just underneath it, what do you have? Supraspinatus tendon. There is a bursa under the acromion. Can you tell me the name of that bursa under the acromion? Bursa hai, yes. Subacromial bursa. Subacromial bursa, right? So subacromial bursa hai supraspinatus tendon. Now, in patients who are predisposed to this condition, who have some anatomical abnormality of the acromion, right? Who have some anatomical abnormality of the acromion, whenever the patient abducts the shoulder, the head of the humerus will impinge on these structures. That is what is impingement syndrome, right? So in predisposed individuals, because of some anatomical abnormality or repetitive overhead abductions, because this is a topic of cumulative trauma or cumulative injury conditions, right? Cumulative injury conditions. So because of this repetitive abduction, what happens? The head of the humerus will impinge on these soft tissues under the acromion, right? Because of this, the structures will get inflamed, and this inflammation will manifest as pain, right? Now, of the 2 structures, which is more important for us In impingement syndrome, supraspinatus tendon is the most important structure that gets impinged and causes pain. Right? That is what you need to understand. Okay? If you've understood this, write down. Pain is because of impingement of the rotator cuff muscle. Which muscle? Supraspinatus. Between which structures? Between the acromion and the head of the humerus. Right? Okay? Is that clear? Now, the question is, in which shoulder movement will there be maximum impingement? In which shoulder movement will there be maximum impingement of these structures? Obviously, it is abduction, right? In abduction. But please understand, there are parts of abduction. So look at this diagram now. Between 0 to 15 degrees of abduction, the action is brought about by supraspinatus tendon. The action is brought about by supraspinatus tendon. I told you, supraspinatus tendon brings about the initiation of abduction. After 15 to 90 degrees, it is the deltoid that takes over the shoulder abduction. And beyond 90 degrees, it is your serratus anterior and trapezius muscle. Please remember, this was an MCQ asked in anatomy in INI set a few years ago. So 0 to 15, it's supraspinatus. 15 to 90, it's deltoid, and 90 and beyond, it is serratus anterior and trapezius muscle. Now, in a patient who has impingement syndrome, which part of the shoulder abduction will be more painful? It will be between 60 to 120 degrees. Why? Why? Because that is the part of movement where there is maximum compression of the subacromial space. Please remember this, very, very important. It is the impingement that is causing the pain. Impingement of which tendon? Supraspinatus tendon that is causing the pain. Right? Is that clear? And the impingement will happen maximally between 60 to 120 degrees of shoulder abduction. So this whole shoulder abduction will not be painful. Only the arc will be maximally painful. Okay? So this is known as your painful arc syndrome. So impingement syndrome is also known as painful arc syndrome because the abduction is not painful. Full abduction is not painful. Might be a little, but the maximum pain will be in the arc of 60 to 120 degrees where there is maximum impingement between the head of the humerus and the acromion. And what is getting impinged? The supraspinatus tendon. Now I would like to demonstrate what painful arc in the painful arc syndrome is all about. You see, this occurs in a condition called impingement syndrome, where I've told you it is the impingement of the supraspinatus tendon between the acromion and the head of the humerus. Now this impingement maximally happens mid-abduction. Now what do you mean by this mid-abduction? Okay, this is my candidate over here. Please, can you start abducting your shoulder slowly? Now you see, as he's abducting, this is the angle of abduction. This is somewhere between roughly around 30 to 40 degrees. Can you keep on abducting? This is around 60 degrees of abduction. This is around 90 degrees of abduction, 120, and then maximal abduction, that is overhead abduction of roughly around 180. All right, so this is roughly around 160 degrees of abduction. This is his abduction. Now, the painful arc syndrome is basically a mid-abduction pain seen in patients with supraspinatus tendinitis. These patients will have maximum pain in the mid of the abduction, that is between 60 to 120 degrees of abduction. Otherwise, the pain is slightly less. The pain is maximal between 60 to 120 degrees of abduction because this is the point where the head of the humerus impinges maximally under the acromion, impinging on the supraspinatus tendon. So this is mid-abduction pain or painful arc syndrome in impingement syndrome, where the patient has pain between 60 to 120 degrees of shoulder abduction. This will lead to supraspinatus tendinitis. The other structures can also be involved. For example, a subacromial bursitis can happen. Supraspinatus calcification can happen. All of these things can happen. But the most important pathology is the tendinitis because of impingement. Right? Okay? Is this clear? And you understood what is painful arc syndrome? Although supraspinatus tendon is involved, leading to supraspinatus tendinitis, but the pain is between 60 to 120 degrees of abduction. This is the arc of abduction that is painful. Now, can you tell me, how will you diagnose this condition? clinically. Most of these conditions are diagnosed clinically with provocative test. What is a provocative test? It will provoke the symptoms. You have two important tests you should know for your exam. One is Neer's test, other is Kennedy test. So what do you do in these tests? You basically move the shoulder in a particular position, thereby impinging the structures and exaggerating the pain. Okay? So what do you do in Neer's test? In Neer's impingement test, you basically abduct the shoulder. And as you're abducting the shoulder, you're waiting for the head of the humerus to impinge on the acromion, and the moment it impinges, the patient will tell you he has pain. Your diagnosis will be confirmed. Okay? So passively elevate the internally rotated arm in the sagittal plane. Okay? In this plane. You do that, there will be pain. This is your Neer's impingement test. Another test is Hawkins test, which is exactly like Neer's test, except that instead of keeping your elbow extended, you flex the elbow and you press on the wrist. You flex the elbow and you press on the wrist. By doing this, you're abducting, but you don't have your elbow in extension. So with the elbow flexed to 90 degrees, the shoulder is passively flexed 90 degrees and internally rotated. By doing this, you're bringing the head of the humerus close to the acromion, causing the reproduction of the symptoms that is seen in impingement syndrome. Okay, so this occurs in anatomically predisposed individuals who have some abnormality either in the acromion or rarely in the head of the humerus, causing the impingement of the structures. Okay, समझ आया? Now the two important tests for impingement syndrome are Neer's test and Hawkins-Kennedy test. Now, before we begin talking about these tests, let me quickly review what impingement syndrome was. If you recall, impingement syndrome was the impingement of supraspinatus tendon between the acromion process and the head of the humerus. So if you recall, supraspinatus tendon was the tendon that passes through the subacromion space, right, and gets inserted on the greater tuberosity. Now, in patients who have impingement syndrome, whenever the patient would abduct the shoulder, the greater tuberosity would impinge on it under the acromion because the space would get narrowed down. In normal individuals, this space is wide enough, and whenever the patient abducts the shoulder, it accommodates the supraspinatus tendon comfortably. But in individuals with impingement syndrome, there will always be this pain whenever the patient abducts. So the provocative tests for impingement syndrome are number one, Neer's test and Hawkins-Kennedy test. Now let me demonstrate Neer's test first to you. The first thing you would do is stabilize the scapula, and then you would forward flex or elevate the shoulder all the way up to 180 degrees. Now, normally, this is a painless maneuver in individuals. But if a patient has impingement syndrome, on performing this maneuver, the patient will complain of pain. This is known as Neer's test. Now, if you want to look at it, understand how this happens. Normally, when I forward flex the shoulder, this is what happens. But in individuals who have impingement, on performing this maneuver, the space is narrowed down and the supraspinatus tendon is impinged, and this causes pain to them. This is known as Neer's test. Now, what is Hawkins-Kennedy test? Hawkins-Kennedy test is another passive test for impingement syndrome. In this test, again, you stabilize the scapula and then you forward flex the shoulder to 90 degrees and then flex the elbow to 90 degrees. Now, keeping your hand under the elbow, you basically maintain this posture. Now, there are two ways of doing it. You can either internally rotate the shoulder with the help of the wrist, or you can internally rotate the shoulder with the help of the elbow. So basically what you have done is you have forward flexed the shoulder, flex the elbow to 90 degrees, and now you're internally rotating the shoulder, aggravating the impingement. Let me show you. So this is the shoulder. It is nicely forward flexed, and now you're internally rotating. On internally rotating, can you imagine what is happening? On internal rotation, the space is narrowed down, and this causes impingement. This is known as Hawkins-Kennedy test. So quickly recall, this is Neer's test for impingement syndrome, and this is Hawkins-Kennedy test for impingement syndrome. So how do you treat this condition? Usually it is conservative. Avoid painful overhead activities that are exaggerating the pain. Give the limb some rest. You can use NSAIDs to suppress inflammation and get rid of pain. You can also inject steroids to control that. So some stretching, some strengthening exercises, physiotherapy will help, NSAIDs will help. Now, rarely you might need to intervene. What will you intervene? You can inject steroids under the acromion, that is in the subacromial space, thereby suppressing the inflammation of the supraspinatus tendon and minimizing the symptoms, number one. And number two, if anatomically the acromion is abnormal, meaning the gap between the acromion and the head of the humerus is unnaturally reduced, what you can do is you can arthroscopically go inside and shave off some of the acromion underneath, thereby increasing the gap between the head of the humerus and acromion. That is known as subacromial decompression. You can do that. Okay? You can do that. Okay? Is this clear? Impingement syndrome is clear. So what are the takeaways here, friend? In impingement syndrome, anatomically predisposed individuals, the gap between the acromion and the head of the humerus is reduced. And whenever the patient abducts the shoulder, supraspinatus tendon gets impinged between the head of the humerus and acromion and causes pain on abduction of the shoulder, particularly which part of abduction? 60 to 120 degrees, that is mid-abduction, that is known as painful arc syndrome. What are the tests that you use to diagnose this condition? Neer's test and Hawkins-Kennedy test. So the next condition we are talking about now is rotator cuff tear. And if this tear is not controlled in time, it will lead to arthropathy, that is pathology of the joint. Rotator cuff tear, arthropathy. We'll understand these terms. Please follow the story. What is the story here? Rotator cuff muscle of one of the four muscles is torn. And when it is torn, what will happen? The patient will be unable to perform the action of the torn tendon, right? First. Or in other words, the patient will have difficulty performing the action of the torn tendon. Or if you ask the patient to perform a particular action against resistance, the pain may be exaggerated. Samajh aaya? Right? Pain may be exaggerated. All of these things will happen. So what is this rotator cuff tear? And what is this rotator cuff tear arthropathy? Please understand that one of the tendons tear. Most commonly, which tendon will tear? It is the supraspinatus tendon. In fact, it is the most commonly injured tendon in the whole body. So obviously, it will be the most commonly injured tendon in your rotator cuff also. Right? In the lower limb, the most commonly injured tendon is tendoachilles. And this is an MCQ that is asked sometimes. So overall in the whole body, the most commonly injured tendon is supraspinatus, followed by tendoachilles. In lower limb, tendoachilles. In upper limb, supraspinatus. Also on a side note, one more question, which is a forgotten tendon of the rotator cuff. I told you there are four rotator cuff tendons: supraspinatus, infraspinatus, teres minor and subscapularis. Subscapularis is considered as the forgotten tendon of the rotator cuff, and the reason is very simple, because it inserts the lesser tuberosity and all the other three tendons insert greater tuberosity. Okay, some MCQ you should know, you know. Now, why does the rotator cuff tear happen? Usually it is degenerative, and usually it occurs in elderly population. Because of degeneration, it tears off. But if it happens in young people, it is usually because of trauma, not very common, unless you are an athlete and you are performing a certain movement that can risk your tendon, leading to tear. But usually it is degenerative, usually occurring in elderly patients. So can you imagine what will happen? The patient will again present to you with shoulder pain. Right? You see, all of the patients are presenting to us with shoulder pain, whether it's a frozen shoulder, whether it is impingement syndrome, whether it is rotator cuff tear. So the difference here is that here, the torn tendon's action will be restricted. For example, if supraspinatus is torn, abduction will be restricted. Or if you ask the patient to abduct against resistance, the pain will be exaggerated. And that is how we have provocative tests to make the clinical diagnosis. So, in clinical features, there will be pain at the shoulder, restriction of shoulder movement, increased pain on movement against resistance, particularly of the torn tendon. Right? I've told you everything is written right. Just listen to me, try to understand. And you can pause the video and make your beautiful, wonderful notes. But please listen to me, understand the story, understand how the patient will present to your OPD. And once you understand that, on the exam, you'll be able to make a diagnosis. And once you make the diagnosis, only then you will be able to answer the MCQ. Okay? So let's quickly review the rotator cuff muscles. I've already told you. We have supraspinatus, infraspinatus, teres minor and subscapularis. And I've already told you their nerve supply: suprascapular, axillary and upper and lower subscapular nerve. You also know their actions. Supraspinatus is initiator of abduction, that is 0 to 15 degrees. Infraspinatus and teres minor are external rotators. Subscapularis is the internal rotator of the shoulder. Tests. we will discuss now. For example, if say your supraspinatus is torn, which movement will be painful against resistance? Obviously, abduction. If infraspinatus or teres minor is torn, which movement will be painful against resistance? Obviously, external rotation. And if subscapularis is torn, which movement will be painful against resistance? Internal rotation. So you have provocative tests for that. These are the names, but I'll show you the ones that are important so that you will be able to answer on MCQs. So quickly look at this. Which action is happening here? Which tendon is contracting to give you the action here? This is your supraspinatus tendon, right? Supraspinatus tendon contracting is giving you abduction of the shoulder. So what are the tests for supraspinatus tendon tear? You have empty can test. You have Job's test. You have empty can test and Job's test. What is empty can test? Basically, you're asking the patient to pretend that he's emptying a beer can or a Pepsi can. He's emptying it like this. So in this movement, you ask him to abduct against resistance. Look at the diagram. And in this movement, if there is pain, it is because of supraspinatus tendon tear. Similarly, there is something known as Job's test. You ask the patient to abduct against resistance with his thumb facing downwards. He's abducting against resistance, and if supraspinatus is torn, there will be pain. So supraspinatus clear, remember, empty can test, beer can test, Job's test, right? Now, empty can test, beer can test, or Job's test is the test we perform for supraspinatus tendon tear. Among the rotator cuff tear or rotator cuff injury tests, this is one of the most important tests we perform. So in this test, we basically ask the patient to forward flex both the shoulders in the scapular plane and internally rotate the shoulder so much so that the thumb points towards the floor. Can you do that, sir? So the arm is forward flexed roughly around 90 degrees in the plane of the scapula and the thumb is pointing downwards. That is the reason it is called empty can test or beer can test, because you're supposed to empty the can or empty the beer can holding it like this. So anyways, coming back to the original posture of forward flexion of 90 degrees in the plane of the scapula with the thumb facing towards the floor and downwards. Now the aim of the test is to basically provoke the symptoms of supraspinatus tendon tear. So we will ask the patient to now abduct the shoulders while we provide resistance to see if there is either pain on that movement or weakness on the affected side. So before you do it, I will try to provide resistance here and ask the patient to abduct the shoulder against resistance. Now on the pathological side, there will be either weakness or the patient will have pain. If you can't appreciate the angle here, I will show it to you from a different angle now. Both the arms abducted 90 degrees forward flexed in the plane of the scapula, and I'm providing resistance against further abduction, and the side which has supraspinatus tendon tear will either be weak or be painful for the patient to abduct. This is your empty can test, beer can or Job's test. So empty can, beer can, Job's test. Okay, these are the names that you should know. You understood how they are doing it, why we are doing it, right? Now for subscapularis, you have lift off, belly press, bear hug. What is this? Basically, you're asking the patient to perform internal rotation against resistance. So how will you internally rotate? You press your own belly. You press your own belly, you're resisting the internal rotation of the shoulder, right? So this is belly press test. What is this? This is lift off test, where you ask the patient to keep the dorsum of the hand on the lower back and then lift it. Then lift it. By lifting the hand from the lower back, what are you doing? You're further internally rotating. You're further internally rotating, and it will be painful if there is a subscap tear. This is lift off test. Okay? Are you following? This is lift off test. What is bear hug test? Can you imagine hugging your fat friend? You're hugging your fat friend. When you hug your fat friend, you're internally rotating the shoulder, right? So if you have a subscap tear, it will be painful. So bear hug, belly press, lift off test is for subscapularis. And for supraspinatus, what do you have? You have Job's test, empty can test, beer can test, full can test, whatever you want to call it. All those tests are available. Now another test for a rotator cuff tear or rotator cuff injury for subscapularis muscle or tendon particularly is your belly press test or lift off test or Gerber test. Now they sound similar, but they are slightly different. So in belly press test, we are basically asking the patient to press their own belly, and we are basically intending for them to internally rotate the shoulder. So that is the action of the subscapularis muscle, and on performing that action, we will apply resistance and we will notice either weakness or pain to provoke the symptoms of subscapularis tendon tear. So this is what I will ask this gentleman to do. Sir, can you press your belly? And I'll ask him to press his belly against the resistance that I'm providing with my hand. On performing this action, he will either have pain or weakness, suggesting there is a subscapularis tendon tear. Another test for subscapularis tendon tear is lift-off test, also known as Gerber test. In this test, I will ask the patient to turn around and show me his back. I'll ask the patient to place the hand, the dorsum of the hand, on the lower back. So this is essentially a position of already a shoulder in internal rotation. Now I will ask him to lift off his hand from his lower back, and as he's doing that, I will apply some resistance. Go ahead, sir. I'll apply some resistance. On this maneuver, if he has pain or weakness, or if he's unable to perform this internal rotation action, it means that his subscapularis tendon is either torn or injured. This is known as lift-off test or Gerber test. What about for teres minor and infraspinatus? They are the external rotators of the shoulder. Na? They are the external rotators of the shoulder. We have something known as Hornblower's test. If the patient pretends to blow a horn, he has to externally rotate the shoulder. If his external rotators are torn, he will have pain doing that. So you have Hornblower's test. Okay? So these are the clinical tests you should know for your exam. What will be the treatment? The treatment is again very simple. Avoid the painful overhead activities that have cause this tear, because I've told you the most common reason is degenerative seen in elderly. You can perform physiotherapy, you can give NSAIDs and analgesics to control the pain. You can also give steroid injections, or not infection, steroid injections to suppress the inflammation, but it's usually not advised much because steroid itself has a potential to cause a tendon rupture. You can go for repair if repairable. Arthroscopically, that is what I do. You put scopes inside and find the torn tendon and repair it. Because if you won't repair it in time, what will happen? What will happen eventually is that the shoulder will get disturbed. You see, remember, the anatomy of the shoulder is very unique, that it is stabilized mostly by muscles. The rotator cuff muscle, the deltoid, and the long head of biceps. The bony stabilizations is not there. The shoulder, by design, is a less stable joint. You know this from upper limb trauma. It is a less stable joint, and that is why it is a very mobile joint. So whatever little stability it has because of these tendons, and if they are torn, that stability is gone. And because of this, the shoulder joint will become unstable, leading to arthritis, and this is what we call as rotator cuff tear arthropathy. Are you following me? This rotator cuff tear arthropathy is an end result of a neglected rotator cuff tear. Okay? So how will you manage a tear? Repair it. If it's repairable, repair it. What if it's irreparable? If it's an irreparable tear and the patient is young, please remember this was an MCQ that was asked a few years ago in AIIMS exam. If it's a young patient who has an irreparable rotator cuff tear, you go for something known as tendon transfer using latissimus dorsi tendon. And if it's an elderly patient, you go for something known as reverse shoulder arthroplasty, and this was the MCQ, and I'll show you how. So what is arthroplasty? You know, reconstruction of the joint, or replacement for simple language. So normally when you perform a shoulder arthroplasty, you put the ball at the side of the head of the humerus and socket at the side of the glenoid. That is a normal shoulder arthroplasty. In a reverse shoulder arthroplasty, you change the physics here. You put the ball at the side of the glenoid and the cup at the side of the humerus. And you do this in order to increase the length of the deltoid. And by increasing the length of the deltoid, you're basically allowing more power to the deltoid to compensate for the loss of the rotator cuff. Okay. Anyways, you don't need to know that. What you need to know is that if it's an irreparable rotator cuff tear seen in an elderly patient, you go for reverse shoulder arthroplasty. If it's an irreparable rotator cuff tear in a young patient, you go for tendon transfer. Okay. Right? Clear? Now, listen to me. I've told you that if there is a rotator cuff tear, shoulder will become unstable. And because of this instability of the shoulder, other structures around it will get damaged and degenerated. Among the other structures that can get damaged and degenerated, one important tendon is long head of biceps. So if you go back to the shoulder anatomy, you will notice this important structure. What is this? This is the long head of biceps. Right? It's going just over the head of the humerus like this. So if there is a rotator cuff tear that will disturb the stability of the shoulder joint, what will happen? This tendon will take more weight of the shoulder, and hence there will be degeneration of this long head of biceps. And because of this degeneration, it will tear. And what will happen when it tears? Look at this. When it tears off, the muscle will crumple and bulge. The muscle will collect distally and bulge, and this bulge of biceps, because of the tear of long head of biceps, is what is known as your Popeye sign. Okay, you understood now? So what is Popeye sign? It's a pronounced bulging of the muscle, the distal aspect, the biceps region of the arm. It is clinically apparent when there is a complete long head of biceps tendon tear, which causes the distal migration of the long head of biceps. Are you following me? So because of rotator cuff tear, the shoulder stability is compromised, and this instability causes pressure or degeneration of the long head of biceps, because of which it tears because of degeneration, and once it tears, it accumulates distally, giving you a bulge clinically like Popeye, the sailor man. Clinically, it will look something like this. This is known as your Popeye sign. Okay, Popeye sign. Now, the last thing before I proceed further is I have one question. Now, the patient can present to you with adhesive capsulitis. The patient can present to you with a rotator cuff tear. The patient can present to you with impingement syndrome. Now, in all these three conditions, if you take an injection of local anesthesia and inject it in the subacromial space. So, please understand, this is the acromion, this is the head of the humerus. Imagine. Into this space, if you inject local anesthesia into this space, of the three conditions, in which condition the pain will decrease? Obviously, the condition which has pathology in this region. Which condition is that? Subacromial impingement is the impingement syndrome. So only in impingement syndrome, once you inject anesthesia in the subacromial space, the pain will come down, and hence the range of movement of the shoulder will increase. There will be no change in adhesive capsulitis, and there will be no change in rotator cuff tear. Why no change in adhesive capsulitis? Because it is adhesion of the capsule that is causing the pain. And it is the capsule. It's nothing to do with subacromial space. And why not in rotator cuff tear? Because it's a tear in the tendon. How will a local anesthesia improve the range of movement when there is a tear in the tendon? Tear, hai na? Range of movement will not improve. There is an actual tear. Here there is impingement, and because of impingement, the patient has pain. And because of pain, the patient is hesitant to move the shoulder, particularly between 60 to 120 degrees. And if you inject the local anesthesia into the subacromial space, this impingement pain will go away, and hence the patient will increase the abduction and the range of movement will increase. Is that clear? And that is what is written here. So pain decreases and range of motion increases upon injection of a local anesthetic agent into the subacromial space only in impingement syndrome, but not in rotator cuff tear. That is what I want you to remember. So the takeaway for rotator cuff tear or rotator cuff tear arthropathy is that you need to remember the names of the tests. Most importantly, for supraspinatus, you need to remember the names of the test. You also need to remember the management of rotator cuff tear, if the tear is repairable or irreparable. And also, last but not least, what will happen to the range of movement if you inject a local anesthesia into the subacromial space. This will help you make the diagnosis and answer your questions on the exam. One quick question before I move further. What will be the investigation of choice for rotator cuff tear? X-ray, MRI, CT scan, ultrasound? Answer is MRI, because we are looking for a tear in the tendon. You're looking for tear in the tendon. X-ray will not show you any tear in the tendon. So MRI is the investigation of choice for rotator cuff tear. Now moving on to the regional conditions that occur around the elbow. There are two important conditions here. Very easy. Tennis elbow and golfer's elbow. And just like everything else, everything is written in the PPT. Pay attention to the story that I'll tell you about the patient, and then you can write down your notes from the PPT. Right. So first is tennis elbow, also known as lateral epicondylitis. Okay. Now before I begin and tell you anything, I want you to sit down right now and put your hand on the elbow. Okay. Feel your medial condyle and the lateral condyle of the humerus. Now you extend your wrist and flex your wrist. What are you noticing? On extension of your wrist, what are you noticing? There is an increase in the bulge on the lateral side. And on flexion of the wrist, there is increase on the bulge on the medial side, which means your wrist extensors are originating from the lateral side and your wrist flexors are originating from the medial condyle. So extension, lateral condyle, flexion of the wrist, medial condyle. ठीक है ना? If you understand that, that is more than enough. We'll proceed further. So what is tennis elbow, or also known as lateral epicondylitis? It's a cumulative trauma or cumulative injury disorder where upon frequent or chronic wrist extension, there is pain and inflammation at the lateral condyle of the humerus. That's the story. Okay? Understood na? Because of wrist extension, there is inflammation at the origin of the wrist extensors. Similarly, what will be medial epicondylitis or golfer's elbow? Upon wrist flexion, overuse of wrist flexors, there will be inflammation over the medial condyle of the humerus. That is the story here. Why does it occur? Repetitive trauma disorder. Okay. So tennis elbow, it is basically lateral epicondylitis that occurs because of overuse of wrist extensors. So who are these people? Obviously tennis players who are giving a lot of backhand, practicing a lot of backhand. In fact, most of the patients are not tennis players. These are normal people just like you and I who are performing activities that bring about a lot of wrist extension. So what are these activities? Motorbike riders. Motorbike riders. Your nurses in the hospital who are measuring blood pressure all the time. Okay? Measuring blood pressure all the time. Motorbike riders, I've told you. Or a carpenter who's hammering all day long. Whose wrist extension is happening again and again and again. Right? And golfer's elbow is when you overuse your wrist flexor. So who are these golfers? Golfers, they use the golf club, hit the golf ball. So they will be flexing their wrist. So there will be medial epicondylitis. In fact, in golfers also, tennis elbow is much more common than golfer's elbow. Right? So please remember that statistically, tennis elbow is very, very common. Most of you will have it. Okay. So here what he's doing, he's flexing the wrist by trying to hit the ball. He's flexing the wrist. So look at the muscles contracting here. Medial epicondylitis. That is the story here. So this will be a patient who comes to you with pain around the elbow and you are starting to examine the wrist. The patient will tell you, sir, why are you examining the wrist? Because you want to look for pain on exaggeration of wrist extension against resistance. You want to look for tennis elbow, you ask the patient to extend the wrist against resistance. If you want to look for golfer's elbow, you ask the patient to flex the wrist against resistance. I'll show you the test. Everything is here. Just pay attention. Okay, so this is a table differentiating tennis elbow with golfer's elbow. And overall, this is more common, friends. Lateral epicondylitis, medial epicondylitis. It is because of inflammation of the common extensor origin of the wrist. Here, common flexor origin of the wrist. There are so many extensors of the wrist. There are so many flexors that cause flexion of the wrist. So which is the culprit muscle? Usually the culprit muscle here is extensor carpi radialis brevis. Sometimes they ask you this as an MCQ. The culprit muscle here is flexor carpi radialis. Usually. Okay. Now how do you diagnose this condition? I've told you, you ask the patient to extend the wrist against resistance to diagnose tennis elbow. And you ask the patient to flex the wrist against resistance to diagnose golfer's elbow. Very simple, right? So tell me how. Ask the patient to extend the wrist against resistance. The extensors contract, pain will be exaggerated, lateral epicondylitis. Name of the test is Cosen's test. Similarly, if you ask the patient to flex the wrist against resistance, the flexors will contract. There will be pain at the medial epicondyle. That is known as reverse Cosen's test. Now let me demonstrate you the tests for tennis elbow and golfer's elbow. If you recall, what was tennis elbow? Tennis elbow was lateral epicondylitis. It was an overuse injury of people who constantly extend their wrist, right? And golfer's elbow was an overuse injury in people who constantly flex their wrist. So a patient with tennis elbow would have pain over the lateral epicondyle, and a patient with golfer's elbow would have pain over the medial epicondyle. So let's start with the test for tennis elbow, the Cosen's test. What I will ask the patient to do is keep the forearm comfortably on the table with the elbow slightly flexed and the forearm in prone position. I'll ask the patient to deviate the wrist slightly radially, and then I will keep my thumb just distal to the lateral epicondyle. So I'll feel for it. This is the lateral epicondyle, and just distal to it, I'll put my pressure. Then I'll ask this gentleman to extend the wrist, and I will apply resistance against that extension. The moment I execute this maneuver, there will be pain near my thumb, and the patient will classically tell me that there is pain under my thumb, which I am pressing. This is known as Cosen's test. Cosen's test is the clinical test for tennis elbow. Now let me demonstrate the test for golfer's elbow or medial epicondylitis to you. What is it? It is basically the insertional tendinitis of the common flexor origin, where the patient would complain of pain around the medial epicondyle on flexion of the wrist. So all you have to do is ask the patient to comfortably place their elbow on the table, but I would prefer keeping it on the palm of my hand because it allows me the posture to press on the medial epicondyle with my thumb. And that is what I'll be doing. I'll apply pressure over the medial epicondyle or just distal to the medial epicondyle with my thumb. Now with the forearm in supination, I'll ask the patient to flex the wrist, and as he does, I apply resistance to it. On application of resistance to the flexion of the wrist, the patient will complain of pain just under the place where I am keeping my thumb, that is just distal to the medial epicondyle. This, my friends, is your reverse Cosen's test, the test for golfer's elbow or medial epicondylitis. So Cosen's test, reverse Cosen's test. There is one more test if you want to know. It's known as Maudsley's test, that is for tennis elbow. Okay. Now what is the treatment? The treatment is rest, immobilization, NSAIDs, physiotherapy, steroid injection and surgical intervention, just like all the conditions we have been discussing so far. So what will you give? Rest, activity modification, splinting. We have a brace, very important, MCQ was asked. It's called counter force brace. I'll talk about it. NSAIDs, physiotherapy, steroid injection and surgical intervention. This is what you can do. Now what is this counter force brace that you can give? Listen to me first, then you can write down because everything is written here. So you apply a brace just distal to the lateral condyle. So what will happen? This brace will act as a constriction band around the extensors and flexors. So whatever force that is being generated by extending the wrist, the muscle contraction will happen only till this brace, not beyond that, because this brace will act as a new constriction band, preventing the contraction of the muscles to reach the origin, thereby relieving it from any kind of movement, allowing it time to heal. That is the principle of counter force brace. It is countering the force acting on the muscle. Okay? So extensor muscles attach and pull on the lateral epicondyle. We know that, causing irritation and injury over time, repetitive or cumulative trauma disorder. Counterforce brace compresses the extensor muscle, removing the tension to prevent pulling of the lateral epicondyle, hence providing time to rest and heal for the inflamed part. That is the aim of using the counterforce brace. Majority of the patients will be relieved by using counterforce brace. So if you are a patient who has tennis elbow, you can start NSAIDs and use counterforce brace. Okay? But nowadays we have a modern modality of treatment known as orthobiologics. This is a wonderful modality of treatment that will accentuate or accelerate healing process of these kind of conditions. And they are very useful, particularly in tennis elbow. So what do? You take the patient's own blood and you inject it at the inflammation side. Why? Because this blood will have a lot of healing factors, a lot of growth factors that will suppress the inflammation and cause healing of this injured tendon, right? Cumulative injury or cumulative trauma disorder. The problem with blood was that it contains WBCs also. So apart from healing, it also increased inflammation. So thereby they removed the WBCs from the blood. What are we left with? You were left with a platelet-rich plasma, and they injected that, causing healing. So platelet-rich plasma helps in healing. Nowadays you can use stem cells also, which can be harvested from adipose tissue, bone marrow or periosteum of the patient, and these stem cells, once injected at the site of pathology, help in regeneration and healing. So for tennis elbow, don't forget Cosen's test and don't forget counterforce press. Now moving on to the conditions that occur at the hand and the wrist. So the first condition we are going to talk about is de Quervain's disease. So what is it basically? Listen to the story. Like I promised, everything is written. Just listen. So it's a tenosynovitis. What is tenosynovitis? Tendons, they are surrounded by synovium. And these synovial sheets, if they get inflamed, you call it synovitis of the tendon, right? So tenosynovitis. So these synovial sheets around the tendon, they get inflamed. Why does it get inflamed? Again, tell me, it's cumulative injury disorder. There is a repetitive activity because of which they get injured and they get inflamed. Okay, so this is de Quervain's disease. So there is tenosynovitis. Of which tendons? The tendons in the first extensor compartment of the wrist. So if you recall, your wrist has 6 dorsal or 6 extensor compartments. So 1, 2, 3, 4, 5, 6. The tendons passing through the first compartment are the ones that are affected. So which are these tendons? There are two important tendons, abductor pollicis longus and extensor pollicis brevis. Very, very important. Okay, abductor pollicis longus and extensor pollicis brevis. This question has been asked so many times that it's not even funny anymore. So which are the tendons involved in de Quervain's disease? Abductor pollicis longus, extensor pollicis brevis. These tendons, because of overuse, they get inflamed, leading to tenosynovitis and cause pain to the patient. This is de Quervain's disease. Usually occurs more in females than males. So write down the points. Stenosing tenosynovitis. Stenosing means narrowing. Stenosing tenosynovitis of abductor pollicis longus and extensor pollicis brevis at the first dorsal compartment of the wrist. Females more than male. Obviously, the most common cause is overuse. Other causes are rheumatoid arthritis. That's it. So they will complain you pain over the radial styloid. How will you diagnose this? Usually a clinical diagnosis, provocative test. Two tests, Finkelstein and Eichhoff test. Finkelstein is the one that is frequently asked on your exam. So what are you doing? You're basically exaggerating the symptomology by causing stress to these inflamed tendons. How do you do it? In Finkelstein test, you take the patient's thumb and you extend it and you stretch it and you bring it down like this. You stretch it and you bring it down like this as shown in the image. When you stretch it and bring it down like this, these tendons that are inflamed passing to the first dorsal compartment will cause pain. This is known as Finkelstein test. So de Quervain's disease, Finkelstein test. Another test is Eichhoff test, where you ask the patient to keep the thumb in the palm and close the palm. Keep the thumb in the palm and close the fist. Now without flexion and extension, keeping it absolutely neutral, you ask the patient to deviate the wrist ulnarly, thereby stretching these tendons. When the patient deviates the wrist ulnarly, he will have pain here. Now you try this. You're normal, right? You try this. Put your thumb in the palm, close the fist, keep it absolutely neutral, no flexion extension, absolutely neutral, and deviate the hand ulnarly. There is some catching. You're normal and you have some catching. Imagine what will happen to the patient who has de Quervain's disease. He will scream in pain. Now let me demonstrate the clinical tests for de Quervain's tenosynovitis or de Quervain's disease to you. Now tell me, what is de Quervain's disease? It is the tenosynovitis of two tendons. Which are those? Abductor pollicis longus and extensor pollicis brevis. Now where are they located? They are located in the first extensor compartment of the wrist. Anatomically, where is it? It's just over the radial styloid process. So in these patients with de Quervain's disease, what happens is there is inflammation of these two tendons. And because of this inflammation, the patient will have pain over the radial styloid. Now as a clinician, my aim is to provoke the symptoms, to reproduce the symptoms, to make the clinical diagnosis. So how will I go about doing it? I will stretch them and cause pain, and that is when my clinical diagnosis is confirmed. So I have two tests at disposal. First is Finkelstein test. So what do I do in Finkelstein test? I basically rest the forearm on the table and I bring the wrist at the edge of it. And then I will grab the patient's thumb and pull it towards the palm, but ulnarly. On doing this maneuver, there will be pain reproduced over the radial styloid. This is known as Finkelstein test, and this is a classical test that is asked as an image-based question on your exam. The other test for de Quervain stenosynovitis is Eickhoff test. It's Eickhoff test. So what do you do in Eickhoff test? You basically place the patient's thumb in the patient's palm and ask the patient to close the palm and make a fist. Now with the fist closed, you will ulnarly deviate the wrist, trying to stretch these two tendons passing over the radial styloid and hence reproduce the pain of de Quervain's disease. This is Eickhoff test and this is Finkelstein test for de Quervain's stenosynovitis. That is de Quervain's disease. Tell me the treatment. Rest, immobilization, NSAIDs, physiotherapy, splint, steroid injection and surgical release. By now you have become experts. Very good. Next condition is Dupuytren's contracture. So what is this Dupuytren's contracture? First important point is it's not a cumulative injury disorder. It occurs because of unknown reasons, idiopathic. ये MCQ है. It is idiopathic. So it is an abnormal fibrosis of your palmar fascia or palmar aponeurosis, and we don't know why it occurs. So there is fibrosis of your palmar fascia, and this fibrosis will lead to a cord or a band-like structure that forms, eventually leading to the flexion of your fingers. That is what Dupuytren's contracture is. Mostly involves the ring finger and mostly involves the metacarpophalangeal or the MCP joint. Okay? So these are the points that you can see. There is a band or a cord-like structure that is formed here, causing the flexion of the finger. So it's abnormal fibrosis of palmar aponeurosis in the form of a nodule or a band or a cord. Occurs more in males than females, and the most common cause is idiopathic, which is an MCQ. Okay, whenever they say there is something that is idiopathic, sometimes they can ask you an MCQ. Like for example, what is the most common cause of CTV? Idiopathic. DDH? Idiopathic. Carpal tunnel syndrome? Idiopathic. MCQs hai, right? Other causes are diabetes mellitus and chronic alcoholics. Okay, chronic alcoholics. So because of this, what happens? The finger starts to bend, and this is known as Dupuytren's contracture. That's it. The most commonly involved finger is ring finger, and the most commonly involved joint is metacarpophalangeal joint. These are the things you need to remember, right? Okay. Now, there are ectopic Dupuytren's contractures also. If it occurs in the penis, you call it Peyronie's disease. If it occurs in the soles of feet, you call it Lederer's disease. Let me show you. This is your fibrotic plaque here, causing a bend in the penis, Peyronie's disease. These are your collagen contractures seen in Lederer's disease. What is the treatment? Usually it is treated conservatively without any intervention. Sometimes you can inject collagenases. Usually it is conservative. You don't have to intervene much because the restriction of the movement of the contracture is not significant. You can use collagenases to basically relieve the contracture. But if the contracture becomes significant, then you have to go and remove the abnormal fascia. And this was asked as an MCQ one time, very, very long time ago. If the MCP contracture is more than 30 degrees and PIP contracture is more than 15 degrees, then you go and remove the fascia. That is known as fasciectomy. You can write down here. It's written. Okay. Like I said, I promised. Everything is written. You can write down. Just pay attention. Listen. So very rarely might require surgery if the MCP contraction is more than 30 degrees and IP contraction is more than 15 degrees. Otherwise, the treatment is usually conservative. Now, recently, a few years ago, there was an MCQ that was image-based question asked in your INI set exam, if I recall correctly, and they showed a diagram of a patient showing contracture in all the fingers. That was a diabetic chenoarthropathy known as prayer sign. And some of you marked Dupuytren's contracture also. But Please remember, Dupuytren's contracture usually occurs in one or two fingers, can occur in all the fingers, but usually occurs in one or two fingers. Whereas diabetic cheroarthropathy involves all the fingers, and there is contracture and stiffness of all the fingers in a patient who has uncontrolled sugars. So keep that in mind. So prayer sign seen in diabetic cheroarthropathy, where all the fingers are involved and there is thickening of the palms and the skin. This is not seen in Dupuytren's contracture. Dupuytren's contracture, usually one or few fingers are involved, not all of them. And usually here the problem is not sugar, it is idiopathic or it is alcohol. Whereas in diabetic cheroarthropathy, it is uncontrolled sugars. Please remember that. Okay? Are you able to differentiate the two images now? Now, before understanding the next pathology, I want you to understand the zones of hand. What are these zones of hand? You see, hand surgeons provisionally divided the hand into few zones for ease of understanding and for ease of classification, and more importantly, to know what are the structures in those particular zones. So we have zone 1, 2, 3, 4 and 5. So the important point to remember here is that zone 2, which is the part between this area, is considered as the no man's land of Punel. This was a long gone old MCQ that was asked. The reason it is called as no man's land of Punel is because the anatomy of this area is very intricate, and if there is an injury that occurs in this area, the olden surgeons who came up with this term thought that the outcome of any intervention would not be ideal, so they wouldn't want to operate for any pathology that occurred in zone 2. But nowadays, we have advanced instruments and advanced surgeons where the outcomes have improved. But the old term was a no man's land because zone 2 was considered as a very difficult anatomy area for surgery. They called it no man's land of Punel. But that is not important for us. What is important for us is to understand that the flexor tendons, as they pass over the hand, they pass through certain pulleys. Okay, so these are the pulleys that hold the tendon in place. So whenever you move the tendon or cause flexion, these tendons cause particular movement as desired. Okay, so these flexor tendons, they pass through the pulleys. You have annular pulleys that are round, and you have cruciate pulleys that are crossing. Nobody will ask you that. What you need to remember is that A1 pulley is located over the MCP joint. Okay, A1 pulley is located over the MCP joint. Underneath, what will pass? The flexor tendon. As you can see, the flexor tendon is passing under these pulleys. And if you understand this anatomy, then you will understand the next condition, that is trigger finger, where the tendon is swollen because of stenosis of the A1 pulley. Right? So what is that condition? That is trigger finger. Now what is happening in trigger finger? Again, listen to the story. You can write down the notes later. It's a stenosing tenosynovitis. Please remember, it's a stenosing tenosynovitis. What is stenosing here? What is narrowing? It is the A1 pulley that is narrowing. Okay. So A1 pulley is located over which joint? MCP joint. Okay. So this pulley is stenosing. What is happening because of the stenosis? The flexor tendon is swelling because of constantly passing through a stenosed hole. So imagine like this. Either the door becomes small or you become fat. What will happen? You will get stuck. So as the tendon is swollen and the door has become narrowed, as it is passing through the sheath, it will get stuck. Right? See, whenever you flex, the tendons, they pass through the sheath. And whenever you extend, the tendon has to pass through the sheath. The tendon has to constantly glide through that sheath. It has to be smooth. So if there is a swelling, what will happen? It will resist passing through the opening. It will resist passing through the sheath. And that is when the triggering happens. On flexion, because the flexors are strong, you'll be able to flex without problem. But on extension, the swollen tendon, the swollen piece of tendon will be blocked by the A1 pulley, preventing its extension, where you will have to apply more force and suddenly the finger will open like a trigger. Can you see the video here? Suddenly the finger will open like a trigger. That is known as triggering of finger. Nothing to do with guns and triggers. Okay, nothing to do with guns and triggers. Are you understanding what is trigger finger? So, ठीक है, points क्या? Stenosing tenosynovitis of the flexor tendon. Sometimes they ask you which tendon most commonly involved. It is the flexor digitorum profundus. Which pulley is involved? A1 pulley. And it's located over which joint? MCP joint. There is a restriction at the time of extension of the finger. Usually females more than males. And what is the most commonly involved finger? It is the ring finger. Ring finger is most commonly involved. Now, what is the most common cause here? Again, trauma. Okay, trauma is the most common cause. Okay, any doubts here? Trigger finger, FDP, A1 pulley, MCP joint. Now we have to discuss two conditions that occur at the thumb. But before we discuss them, we have to understand the movements that occur at the thumb. Now, can you tell me what are the movements that occur at the thumb? Okay. So what is this movement, friends? This movement is abduction, abduction of the thumb. Okay. This is adduction. This is extension. This is flexion. And this is opposition. Right. So perpendicular to the plane of the hand is abduction, adduction, flexion, extension, opposition. Right. Now you see, between your phalanges and the metacarpal bones, there are collateral ligaments. So similarly for thumb, between the metacarpal and the phalanx, there are collaterals. One is located on the radial side, other is located on the ulnar side. Can you see the diagram here? One is located on the radial side, other is located on the ulnar side. This is the metacarpal, this is the phalanx. These are known as your collateral ligaments. Okay. Upon hyperabduction of thumb, there is an injury that causes hyperabduction of thumb. Which ligament will tear? It will be the collateral ligament of which side? The radial side or the ulnar side? Ulnar collateral ligament. That is what it is. This is known as your gamekeeper's thumb or skier's thumb. Right? So it is gamekeeper's thumb or skier's thumb, where there is an avulsion of the ulnar collateral ligament of the thumb at the first metacarpophalangeal joint. Right. Now what happens? Sometimes there is a tendon that can get that interposed between the injured ligament, prevent its healing. So which tendon will that be? That will be adductor pollicis tendon. And if this adductor pollicis tendon interposes between the ulnar collateral ligament, it will not allow for its healing. This is known as Steiner lesion. समझ आ गया? So if there is a gamekeeper's thumb or skier's thumb, what is it? It's basically avulsion of ulnar collateral ligament of the first metacarpophalangeal joint. Ulnar collateral ligament of the first metacarpophalangeal joint, that is of the thumb. If there is adductor pollicis interposition, you call it Steiner's lesion. That's it. How will you treat it? Thumb spica cast if it's just a gamekeeper's thumb. But if there is a Steiner's lesion, you have to go for surgical repair because this tendon will not allow it to heal. Right? That is the story of gamekeepers or skier's thumb. Gamekeepers of the skier's thumb. Now, you'll ask me, sir, why is it called gamekeepers? Because in olden days, hunting rabbits was called a game. Now, if somebody would hunt a rabbit and if the rabbit wouldn't die because of hunting, there was a gamekeeper. The gamekeeper's job was to quickly go and kill the rabbit to relieve it of the misery of the gunshot injury. So what this gamekeeper would do is go to the rabbit, quickly hold the neck and break the neck. Okay, that was the job of the gamekeeper. So when he would break the neck of the rabbit, he would abduct the thumb and sometimes there could be injury of the ulnar collateral ligament. So that is the story how it got the name gamekeeper thumb. Not very important, but helps you remember things. Now the next condition we are talking about is bowler's thumb. This is seen in bowlers, professional bowlers. Who are these bowlers? Not cricket bowlers. These are bowling alley wala bowlers. That heavy ball that you throw towards pins that are falling down at the end of the alley. Right. That is your bowler's thumb. So what happens here? So these are the professional bowlers who will be practicing bowling again and again. Now remember, how many holes are there at the ball, in the bowling ball? There are 3 holes, right? So these 3 holes, the ball is supposed to be held like this. So the ring of the thumb will be basically taking a lot of burden and weight because thumb is where most of the weight of the bowling ball is transmitted. So this ring of the bowling ball will constantly compress this part of the thumb. Now, all your fingers have nerves passing both on the radial and the medial side. So that is the radial and the ulnar side. So these nerves, they get inflamed because of constant compression. That's what happens here. Because of chronic bowling or professional bowlers who keep on bowling again and again, the ring of the bowling ball will compress their nerve, leading to fibrosis. So it's an ulnar digital nerve of the thumb, and because of bowling undergoes perineural fibrosis, and this causes pain. That's it. So what is gamekeeper's thumb? It's ulnar collateral ligament tear. What is bowler's thumb? It is ulnar digital nerve fibrosis or perineural fibrosis or neuroma formation at the ulnar digital nerve. Right? So what would be the treatment? Ask them to stop bowling or ask them to use some protective gear to prevent its compression. You can give a rest, splinting, NSAID, steroid injection. That is what you can do. Okay? Now let's talk about mallet finger and jersey finger. And trust me, this image has come on your exam so many times that if you go to the exam without knowing this, you might as well not go, because that's how important this is. So what is mallet finger? You see, your extensor tendon comes and inserts here at the base of the distal phalanx on the dorsal side. Right? Now, if you have a hyperflexion injury, if there is a hyperflexion injury, this tendon gets avulsed. So because of hyperflexion injury, this tendon gets avulsed. That is what is happening. Avulsion of the extensor digitorum communis because of hyperflexion injury. Right? That is the problem here. Now what is the manifestation? The manifestation is that since the tendon is avulsed, the patient cannot actively extend the DIP joint. So the DIP will remain in flexion. But passive extension would be fine because you can passively extend it. But active extension is not possible. So passive extension is possible. Active extension is not possible because the tendon is ruptured. If you get an X-ray, what will you find? Depending on where the tear is. If the tear is in the substance of the tendon, you might not find any change on X-ray because there is no bony problem. But if there is an avulsion, then you will find a small bony fragment on the dorsal side on the base of the distal phalanx. Are you following me? So on X-ray, you might find this small bony structure if there is a bony avulsion. But if there is a tendon rupture, you will not find anything on the X-ray. That is what it is. This is mallet fingers. How will you treat it? You give a splint that will keep the DIP in extension. That's known as mallet splint or Stax's splint. Let me show you. This is mallet splint or Stax's splint. Clear? So again, hammer this image into your head. This is mallet finger. Now don't get confused with swan neck deformity, boot neck deformity seen in rheumatoid arthritis. Those things will affect multiple fingers. Here there will be only one finger that is affected because this is a trauma. Okay? Now what is jersey finger on the other hand? Jersey finger is the same thing happening on the flexor side. The flexor tendon comes and inserts at the base of the distal phalanx on the volar side. The purpose is to flex the DIP. Because of hyperextension injury, it can get injured or it can get avulsed. So what will happen? The DIP will remain in extension with inability to actively flex the DIP. But passive flexion will be fine. Passive will be fine, active not possible because the tendon continuity is lost. It occurs most commonly in the ring finger. Avulsion of the flexor digitorum profundus tendon from the base of the distal phalanx on the volar side. Clinical feature, extension deformity of the DIP with inability to actively flex. Passive flexion should be fine. Treatment is again splint. And the last condition that we'll be discussing in the hand and the wrist is ganglion cyst. Very, very important. In fact, it is the most common swelling that you will see at the hand and the wrist. And I'm assuming most of you will have this. So there's this small bulge that you will notice around the wrist. Basically, what is it? It is just an outpouching of your synovium. It is an outpouching of your synovium with its synovial fluid, right? Initially, but later it will become mucinous. So an outpouching of your synovium or tendon sheath. Everything is written, just please understand the story. You can copy it out later. It's an outpouching. It's a unilocular outpouching of your synovium or the tendon sheath. Why does it occur? Degeneration, trauma, many causes are there. And it causes pain and there is a deformity and swelling. And you must have noticed this, it will be seasonal. Sometimes it occurs in winter, sometimes it occurs in summer, sometimes it's painful, sometimes it's painless. That is what a ganglion cyst is, simple. You can conservatively manage it, ignore it, or you can aspirate the content and inject steroids or sclerosants to control it. And if there is a recurrence, you can surgically go in and remove it. Alright, so this is the swelling that I was talking about. Okay, this is the swelling that occurs in the dorsum of the wrist. It is the most common cause of swelling at the hand and wrist. It's a unilocular cystic swelling arising from the synovium. It is an outpouching either from the joint synovium or the tendon sheath. It contains mucinous fluid. Most commonly occurs on the dorsal side. Everything is written like I promised. Treatment: aspirate the contents of the cyst followed by injecting steroids or sclerosants. If there is recurrence, go for surgical excision. That is your ganglion cyst. Now, there is another misnomer here that is called as a compound palmar ganglion. What is compound palmar ganglion? It's a misnomer. It's neither compound nor a ganglion. What is it? It is basically a chronic inflammation of your flexor sheath. The common flexor sheath of your forearm and hand, it goes into chronic inflammation seen in patients of tuberculosis and rheumatoid arthritis. Okay, so whenever there is chronic inflammation, there is swelling. But there is something known as a flexor retinaculum here, under which there is carpal tunnel, right? Remember carpal tunnel syndrome? So this flexor retinaculum doesn't undergo inflammation. So it acts as a constriction band around the inflammation of the flexors of the hand and forearm sheaths inflammation. Okay? Samajh? Did you understand? So there is inflammation of the flexor sheath of the hand and the forearm. Flexor retinaculum acts as a constriction band. So there is swelling here and swelling here, but no swelling here, giving you a shape of an hourglass. Can you appreciate this? Giving you a shape of an hourglass. So it is a misnomer. Chronic inflammation of the flexor sheath seen in tuberculosis and rheumatoid arthritis. Flexor retinaculum divides the swelling into the shapes of hourglass. It acts as a constriction band dividing the swelling. That's it. It's an inflammation of the flexor sheath, whereas the ganglion is supposed to be an outpouching of the synovium. Okay, this is compound palmar ganglion. Now let's talk about the regional conditions of the knee and foot. Let's start with knee first. The first condition we are talking about is chondromalacia patellae. Now again, everything is written, just please understand what it is. Chondromalacia patellae is, chondro is cartilage, malacia is softening of patella. So patellar cartilage becomes soft. Now we don't know why it occurs, but it's usually seen in females, particularly athletes who are performing any kind of sporting activity. Here what happens is the patellar articular cartilage becomes softened and it causes anterior knee pain. Obviously the pain will be on the anterior aspect of the knee, right? So it will cause anterior knee pain. In fact, this is the most common cause of anterior knee pain. What is chondromalacia patellae? And this anterior knee pain becomes severe particularly on getting up from a sitting position and particularly after prolonged sitting. So if a patient is sitting for a very long time and when she starts to get up, she will have anterior knee pain. This is a classical clinical sign of chondromalacia patellae. So what are the points to remember here? It is idiopathic. We really don't know why it occurs. The articular cartilage of patella is softened and causes anterior knee pain. The diagnostic sign is the clinical sign known as the movie sign, which I told you was anterior knee pain on getting up from a sitting position, particularly after prolonged sitting. Right? So the term movie sign has been described for this. Why is it called movie sign? Because whenever you're watching a movie, you're apparently sitting for a very long duration. And after that, when you start to get up, you have anterior knee pain. And that is chondromalacia patellae. Okay. Next condition is Baker cyst. Okay. Again, everything is written. Just please understand. For simplicity of understanding, Baker cyst is what I would call as ganglion cyst of the knee. Right? Particularly occurring on the posterior aspect of the knee. It's that. Right, so what was ganglion cyst? It was a synovial outpouching, right? So this is what it is. So it's a pulsion diverticulum of synovium. Where does it occur? On the posterior aspect of the knee. Okay, it can occur from the joint or it can occur from the bursae. Whereas ganglion could occur from the joint and occur from the tendon sheath, right? So this is same thing, but here at the knee, particularly on the posterior aspect of the knee, the popliteal fossa, we call it a popliteal cyst or a Morant-Baker cyst. Swelling becomes prominent on knee extension. Please look at this. When the knee is extended, the swelling becomes prominent, and on flexion, the swelling disappears. Flexion, swelling disappears. So what are the causes? The causes are osteoarthritis, rheumatoid arthritis, and PVNS. Sometimes because of tuberculosis also it can occur. Investigation is mostly clinical. You can also use ultrasound to see what is the content of the cyst. X-rays will not show you much. MRI is an excess. You don't need to do that. So ultrasound is fine. A treatment is we can aspirate it, but ideally you should go for an excision because there is chance of recurrence. So excision is the treatment. This is your Baker cyst. Not a lot of MCQs will be framed. Mostly the MCQs will be based on the causes. Osteoarthritis and rheumatoid arthritis are the two important causes of Baker cyst. ठीक है, समझ आ गया, right? That's what you need to remember. Now coming to bursitis. What is bursitis? It's inflammation of the bursae. What is a bursae? Bursae is the synovial sac that is around the bones to prevent, to allow for gliding of the tendons over the bone, to prevent friction of the movement, to prevent friction when the tendon glides over the bone. Right, so what is a bursa? It's a synovial sac. What is its purpose? Its purpose is to prevent friction when the tendon is gliding over the bone. Right, so it will be close to tendons which are inserted. There are many parts, there are many bursae in the body which are located all over the body. Now, if you inflame this bursae, either because of overuse of tendons or direct compression of the bursae, they'll get inflamed. That's it. That is bursitis. Now, depending on which bursae is inflamed, you have a term given to it because it's usually associated with a particular kind of activity that triggers its compression. For example, you have a bursa over the olecranon. Right, and as a student you would go to the library and pretend to read all day long sitting like this on the table, right? So you compress this olecranon bursae against the table when you pretend to study all day long. Now you know what you're imagining, but when you're pretending to study, you're compressing that bursae over the table. So this bursae gets inflamed. This is known as olecranon bursitis. Olecranon bursitis is seen in student's elbow. So student's elbow is a term for olecranon bursitis. See, that's how they got their name. So similarly, there are some bursae around the knee that you should know. One right in front of the patella known as prepatellar bursitis, and just below the patella is infrapatellar bursitis. So infra, below the patella, right in front, prepatellar bursitis. So prepatellar bursitis is seen in housemaids. Because housemaids, they get down on the floor to wipe your floor, right? So this bursa in front of the patella, it will get inflamed. So housemaid's knee is prepatellar bursitis. Whereas clergymen are these people, clergy, these popes, these priests who kneel to pray to God. Right? When they kneel, they compress the infrapatellar bursa. So clergyman's knee is infrapatellar bursitis. Student's elbow, I've told you, is olecranon bursitis. Right? Similarly, there is something known as Haglund deformity. That is a retrocalcaneal bursitis, and I'll explain in a bit what it is. But you know the name, right? Retro means behind, calcaneum means behind the calcaneum bursitis. Then there is a weaver's bottom, ischial bursitis. These are weavers who use their feet to constantly move the pedal to run the sewing machine. These are weavers. So because of their constant movement of hip and knee, they will get a ischial bursitis. And there is a Taylor's bunion. Bunion is a bony swelling. It's not a bursitis, truly. It's a bunion, that is a bony swelling. It is a swelling that occurs at the lateral aspect of the fifth metatarsal. That is known as Taylor's bunion. So let me show you what these structures and things are pathologically and clinically. Olecranon bursitis is swelling of the olecranon bursa seen in students. Housemaid's knee is prepatellar bursitis. Clergyman's knee is infrapatellar bursitis. Haglund deformity was a retrocalcaneal bursitis. So behind your calcaneum there is a bursa. And people who wear abnormal footwear, as in sandals or heels, this bursa will constantly get compressed, leading to its inflammation, leading to a calcification, leading to a bony swelling that forms. So this bony swelling will form as a bulge, and this bulge is known as Haglund deformity. That's it. So Haglund deformity is a manifestation of chronic retrocalcaneal bursitis. It's also known as pump-bump deformity because it's seen in people who wear these pump shoes. Pump shoes are these your party shoes which compresses behind the calcaneum. Finally, what is Taylor's bunion? Taylor's bunion is this bony swelling occurring on the lateral aspect of the fifth metatarsal. Right. Also remember what is hallux, varus and valgus. Hallux is toe, varus is moving medially and valgus is moving laterally. So when there is hallux valgus, you will notice that there is a medial bunion. Right. There is a medial bunion. Right. So this is hallux varus, this is hallux valgus. What are you noticing in hallux valgus? That obviously because of the lateral deviation of the toe, there is some overcrowding of fingers. Even though this is a deformity, the patient usually complains of pain. And that is when you go for treatment. Otherwise, deformity is usually neglected. You do not do much for the deformity. You go for pain and its treatment, because deformity treatment is not necessary. It's not important. Pain is something that you should definitely treat. And usually the patients who have hallux valgus and pain are the ones that are the happiest when you give them the treatment, because pain is what is bothering them all the time. So remember, hallux valgus, the lateral deviation of the great toe. There is overcrowding and overriding of fingers that happens because of lateral deviation. Treatment is usually conservative. But if there is significant pain, you can go for surgery. Two names I wanted to remember is chevron or Keller osteotomy. Okay, so this is what happens. There is a lateral deviation of the toe. You can surgically go and remove a wedge of the bone to correct the deformity. And whenever there is a medial bunion or swelling at the first metatarsophalangeal joint, another important differential usually comes to your mind. That is gout. Please remember, this is a very important differential, and I want you to remember these important things to differentiate them. See, gouty arthritis usually has inflammation. So there is local rise of temperature, redness, swelling, warmth, right? Whereas hallux valgus, there is no inflammation. Usually there is no inflammation, unless there is inflammation because of immediate trauma at the hallux valgus or the bunion. Usually hallux valgus does not have inflammation. So no local rise of temperature, no redness, no swelling, just bony swelling will be there. Okay. On an X-ray, what will you notice? In gouty arthritis, there is a destruction of the joint. Whereas in hallux valgus, like I showed you on X-ray, there is no destruction. It's just that it is deformed. And finally, when you aspirate the contents of the first MTP in gout, what will you find? You'll find your classical monosodium urate crystals, right? Those are negatively birefringent crystals. Needle-shaped, that you will see in gout. So with that, we have essentially completed all the things that we wanted to discuss in regional conditions. Let's see if we have understood it or not with MCQs. So let's look at the first question. An elderly diabetic patient comes to you with gradual painful limitation of shoulder movements. There is no history of trauma. All are true of her possible diagnosis except. Now, just based on the history, we don't have much except that she is diabetic and there is a gradual painful limitation of shoulder movement and there is no history of trauma. So possibly adhesive capsulitis, right? Frozen shoulder, right? Okay. Periarthritis is the most probable diagnosis. Possibly true. All movements are restricted. Yes, it's a global restriction of movement, both active and passive. Yes, it's true. Internal rotation is affected last. Rotations are the ones that are affected earliest. External is the first one. So this is not the right statement probably, but let's look. Both active and passive movements are affected. Yes, this is true. The wrong answer is C. So this is the answer here. Okay, na? Right, that's how you make the diagnosis. Usually gradual restriction of shoulder movement, the freezing phase. In diabetic or elderly patients, think of adhesive capsulitis. Next, most common muscle damaged in rotator cuff. It's a fact, straightforward. What is the most common muscle damage in the body? The tendon injured in the body is supraspinatus. And in the rotator cuff, obviously, it is supraspinatus. Right? You know this, straightforward. Moving on. A 40-year-old man was repairing his wooden shed on a Sunday morning. Wow. By afternoon, he felt that the hammer was becoming heavier and heavier. He felt pain in the lateral side of the elbow and also found that squeezing water out of a sponge hurt his elbow. Which of the muscles are most likely involved? Do you have a diagnosis? You're hammering all day long, pain on the lateral aspect of the, pain on the lateral side of the elbow, pain on squeezing the sponge. What is it? Think of it. Yes, it's lateral epicondylitis, tennis elbow. Excellent. So biceps brachii and supinator are the ones that are involved? No. Flexor digitorum superficialis? No. Extensor carpi radialis longus and brevis? Brevis more than longus? Yes, so that is probably it. Triceps brachii and anconius? No. So the answer here is extensor carpi radialis longus and brevis. Did you understand how we made the diagnosis of tennis elbow here? Right, very good. Now Finkelstein's test is used for, straightforward. Please remember the names of the test. You don't have to go into the depths of how to perform the test, but at least know the names of the test for your exam. So Cosen's test, reverse Cosen's test, Finkelstein test, lift-off test, belly press test, empty can test, Kennedy test, Neer's test, all of these things you should know. Make a table and memorize what it is for. Anyways, Finkelstein test is used for De Quervain's disease, right? De Quervain's disease. ठीक है ना? Right. Tennis elbow के लिए, what do you have? Cosen's test. Golfer's elbow, reverse Cosen's test. You know this. Everything is there. You just need to revise. About De Quervain's disease, all are true except, okay, involves extensor pollicis brevis and abductor pollicis longus. Abductor pollicis longus and extensor pollicis brevis. Positive Finkelstein test. Steroid used to relieve pain. Involves extensor pollicis longus. No. It's always extensor pollicis brevis. So the answer here is this. This is the wrong statement. So abductor pollicis longus, extensor pollicis brevis. My God, it has been asked so many times. I told you it's not even funny anymore. Please remember these two tendons passing through the first dorsal compartment. Finkelstein test, Eckhoff test. All are true about Dupuytren's contracture except, okay, thickening fibrosis of palmar fascia. True. Much more common in males. Yeah, true. Associated with alcohol consumption and diabetes. Yes, true. Rarely bilateral and mostly starts in index finger. False. Okay. It's usually bilateral and involves ring finger most commonly. So this is the right answer. Okay. What is the most common cause? Idiopathic. Dupuytren's contraction, most common cause is idiopathic. What is the most common cause of trigger finger? Trauma, alcohol, smoking, drug abuse, idiopathic. Tell me. Trauma, I told you, it's a cumulative trauma disorder. It's a cumulative trauma disorder. Idiopathic is only for Dupuytren's contracture. Trauma is the most common cause of trigger finger. Right? Now, all are true about trigger finger except thickening fibrosis, thickening of fibrous tendon sheath, mainly A1 pulley at the MCP joint. Yes. Astenosing tenovaginitis. Remember, tenovaginitis is equal to tenosynovitis. Same thing, different terms. Stenosing tenovaginitis of flexor tendon of the finger. Yeah. Follows local trauma. Yes. Mainly involves A2 pulley of the finger. No. Simple, straightforward. You know the answer. Okay, next. Housemaid's knee is bursitis of which of the following? This is facts. These are facts. You have to memorize that table. Housemaid's knee is prepatellar bursitis. Housemaid's knee is prepatellar bursitis. Okay, and clergyman's knee is infrapatellar bursitis, and student's elbow is olecranon bursitis. Next question. Ischial bursitis is known as Weaver's bottom. Weaver's bottom. Ischial tuberosity. The bursitis of the ischium is Weaver's bottom. In hallux valgus surgery, the patient who are likely to be most satisfied are, which are the patients who will be most satisfied following a hallux valgus surgery? Those with more pain? Yes. Those with hammer toe? No. Those with no pain? No. Patients at young age? No. Pain. The patients who have pain are the ones that are the happiest when you operate for hallux valgus. And the last question, recently asked in AIIMS, counterforce brace is used in which of the following conditions? Is it tennis elbow, ankle sprain, ulnar claw hand, foot drop? Answer is, you know, it is tennis elbow. Please remember, counterforce brace is used both for tennis elbow as well as golfer's elbow. And ulnar claw hand, what is the splint you use? Tell me. You've read this in nerve injuries. Very, very important. Even if you have not read this in nerve injuries, you should know this by now. Yes. For ulnar claw hand, you use knuckle bender splint. Right? You use knuckle bender splint. And what is the splint you use in foot drop? Foot is dropped. Use foot drop splint. Foot drop splint or ankle foot orthosis or toe raising splint. Toe raising splint. And last question before I end. What is the nerve involved in foot drop? Yes, common peroneal nerve more than sciatic nerve. Very good, very good. Okay, with that we have completed regional conditions. This was a topic which was random because there were conditions from different parts of the body brought under one umbrella to make it easy for you to understand what these conditions are, what are the tests and how to treat them.